Once again. Okay, yeah. Once again, thanks Peter and Bob McCarthy for the opportunity. I welcome all my friends. Today, I would like to share, our experience in pancreas, our clinical allotransplantation or transplantation, as well as for basic diabetes research. Today we want to know why we need, young donor islets, because of their, excellent functional capacity. And how many young donor pancreases are available according to the UNIS donor data, and what are the natural difficulties islets for young donors. Generally we see mantled, or you call embedded islets or trapped islets, and how we overcome to recover those islet cells. And I would like to start with some experience, our historical islet isolation experience with the Liberators enzyme, and our initial effort in University of Pittsburgh and other institutions, how they try to improve the recovery of young donor islets. And importantly, the UCSF, University of California, San Francisco success, in getting good islet yield from young donors using servo enzyme. And in the later stage, how we used split lobe model to study various enzyme combinations, and the importance of extracellular matrix, especially peri-islet basement membrane. And I would like to conclude at the end. Again, as you all know, donor age is an important determinant of the outcome of the islet isolation procedures. Many studies reported that transplanted islet preparation from young donors are associated with better clinical outcome because they are resistant to oxidative stress, cold ischemic challenges, rate, ATP content, their insulin secretory capacity are high when compared to older donor. Islet grafts isolated from young donors allow superior functional outcome, but are often associated with poor isolation yield. This is mainly because of the difficulty in efficiently separating the islets from the surrounding exocrine cells. So many islet isolation centers are likely to turn down pancreas offers from donor aged below 30 years. In this study, Dr. Terry Burney group reported that in spite of isolation and purification difficulties, pancreases from young donors allowed similar islet transplant rates as older donors. Effort should be directed at improving islet extraction in these donors to realize their full potential for islet transplantation. The data from United Network of Organ Sharing, UNIS data for the last 20 years indicated that greater than 30 to 40% of the donors were under the age of 35. Islet laboratories generally try to avoid utilizing young donors due to the islet isolation difficulties, as well as due to the fact that pancreas may be generally smaller in size because it's kind of difficult to get higher BMI donors. We prefer to take higher BMI donors. In young donors, it's difficult to get many higher BMI donors. This data clearly reveals that a large pool of young donor pancreas is available for human islet transplantation, but are underutilized. Islet isolated from young donor remain mantled and embedded by surrounding exocrine cell after enzymatic digestion of the pancreas. Though the surrounding layer of exocrine cells may protect islet integrity, but mantle islets are often lost during the purification process. The release of mantle islets from young donor pancreas is likely due to the composition of the extracellular matrix. These dying acinar cells, obviously it may cause damage to the islet cells. So we prefer to get mantle-free islets from these young donors. Better understanding of cellular tissue matrix composition within the islet exocrine interfaces needed to improve current digestion protocol. For example, whether surrounding exocrines are weaker or these peri-islet basement membrane around the islets are stronger, because some In many studies, Dr. Paul Johnson group reported that islet isolation process remains highly variable, and the current islet isolation enzyme blends are ineffective at digesting pancreas, especially from younger donors with low body mass indexes. And we get larger tissue volume per gram pancreas from the younger donors, almost half, like a 0.4 cc to 0.5 cc we get from younger donor compared to older donor. Sometimes, not only purification difficulties, it's also difficult to infuse large quantities of exocrine cell mass, especially in the case of islet transplantation. In general, purification step causes islet cell loss. An average of almost 30 to 40% loss has been reported, utilizing various different density gradients. But the embedded islets are difficult to separate from acinar cells with the current purification method using density gradient centrifugation. It is therefore obvious that islets from young donors show significantly lower recovery rate because of the inherent difficulty in separating embedded islets from exocrine cells during purification steps. Dr. Terry Burney group clearly showed loss of islet cells from compared to older donors. Although we get large amount of pre-purification islet yield, but purification is again a challenge. We have adapted, rescue purification. That approach helps to recover some islets, but still we continue to lose many islets in the co-bag. We also, don't want islet cells to expose to gradient materials, for during additional purification step. Historically, when we used the Liberators HI, before the development of modern enzymes, from Serva, Roche, and VitaCyte, we observed predominantly embedded. I think my own experience with the Liberators, it is always from young donors. Because we always used this approach and ended up with mantle islets every time. And the composition, the Liberators HI contained about 2,000 unit unit of collagenase and 13 milligrams of thermolyte. In my view, Bob McCarthy is here. In my view, would have added lysine. During my tenure working with Dr. Rita Bottino at the University of Pittsburgh, we had the opportunity to process many young donors, 5 years old, 5 years old, 2 years old, even 6 months old donor. We wanted to get mantle free. I mean, our hypothesis was, attention, we thought that that whole ductal system is very fragile. For example, at the time, Milan group reported this paper. In this paper, their hypothesis was because of the nature of the ductal system, they injected the enzyme at the time of immediately after procurement before bringing to the islet lab. So, we thought maybe the ductal system is very weak, or, as you know, when you inject the enzyme through the ductal system, basically it breaks these exocrine cells and, coming through the exocrine lobule and reaches the peri-islet basement membrane. So maybe this portion of the exocrine cells are weaker. That's why even before enzyme reaches the peri-islet basement membrane to digest, so these clusters are released. Or maybe this portion of the peri-islet basement membrane is very stronger. That's why it's difficult to separate the islet cells from the surrounding exocrine cell. We developed a young donor protocol based on Dr. Rita Bottino's experience and my experience from a static digestion method for non-human primate islet isolation. So our aim was to do a static type of digestion. So we prolonged the enzyme distension for almost like 30 minutes. We wanted to initiate the digestion in the pan, before we move to Ricardi chamber. So after prolonged enzyme distension, we wanted the pancreas to expose to enzyme, minimize the mechanical shaking. So when we put the pancreas in the Ricardi chamber, we added 2 screens and we did extremely slow shaking. We don't really shake the chamber, just mixing the chamber. And we had extra screen, to kind of trap those islets coming from the Riccardi chamber. It allowed the cells to kind of trim a little bit, and then we got like a many mantle free islets. This is the way generally we get with our prolonged distension step and the slow shaking method. We got many mantle free islets. And it is also important to note that even in the native pancreas, we could see large number of well developed islet cells in a native pancreas. And with our approach, after islet isolation, their insulin secretory capacity as well as diabetes reversal capacity, they were kind of really normal compared to our older donor. Then after Liberators HI was withdrawn in the year 2007, clinical islet transplant programs were forced to quickly identify a replacement enzyme blend. We evaluated numerous different enzyme products in various combinations, which contained different amounts of intact and truncated class 1 and class 2 collagenase and a different type of proteases. During this period in 2007, Greg Zart from University of California, San Francisco showed mantle-free islet cells from younger donors utilizing serva collagenase with a neutral protease. Personally, I was thrilled with this result because I thought I will never get mantle-free islets from young donor, because I was under the impression that is the nature of the young donor pancreas. But he showed many nice free islets, from 19 years old, 17 years old, and in one particular case, for example, even the same approach, he didn't have a lot of free islets. The percentage free was only 30%. But the fact that definitely it is possible to isolate mantle-free islet cells with the standard approach. He didn't do any special approach. It's a standard islet isolation procedure. Later he published this as a paper. So I think the important aspect is the collagenase dose. It was like a 1600 Wunsch unit as well as like a 200 DMC units of neutral protease, because the 1600 collagenase is not commonly used even during the Liberators HI isolations. Predominantly we use more than 2000 Wunsch unit, but in these studies it's a smaller, lower collagenase and higher neutral protease. The ratio is different from our historical islet isolation. So immediately, I wanted to try, his approach. One important factor is predominantly these donors were higher BMI. If you see, like they are more than 25. The same approach, like a 200 DMC unit with the 1600 collagenase using serva enzyme in low BMI donors, especially when we accept pancreas for our research, it didn't work. And then the second thought was maybe because of the truncated nature of the collagenase. So in 2007 and all, many laboratories reported that serva enzyme had many truncated collagenase compared to intact collagenase. So we tried in split lobe model for truncated collagenase as well as normal collagenase to see whether we can get free islets, but we didn't really get many free islets with that approach. So then we wanted to really understand the possible reason for free islets. We did the extensive analysis of our islet isolation parameters, including historical isolation with the Liberators HI. It included enzyme dose, distension type, enzyme retention, percentage embedded, nature of the pancreas, how many times we had a successful islet isolation for clinical transplant, how many times we had a failure, and during enzyme distension, how much enzyme stayed inside the pancreas, and whether there is association of enzyme retention with the islet percentage embedded islets, older donor type, plus various enzyme combination. And we analyzed from CIT as our clinical islet transplantation consortium data, as well as CIDED data. So in our analysis, we included donor factor, procurement related, pancreas characteristics, and the distension characteristics, enzyme related, among various different enzymes, and the interventions during digestion at all. So with all analysis, we noticed that collagenase to protease ratio significantly played a major role. So we wanted to test various enzyme combination and ratios in a single pancreas, try to avoid donor variability. So our team members, especially Krishnan Loganathan, tried smaller lobes in static digestion method using 50 cc conicals or 50 cc conicals, or developed a miniature islet isolation method to test various enzyme ratios and combination. But it's difficult to reproduce, with this approach, it was difficult to reproduce the result, or we couldn't really compare the result from one lobe versus another lobe. Then we developed this Trisector pancreas model. Basically, it's a very simple technique. You split the head and digest the pancreas separately. And then we rotate every lobe for each enzyme testing. We used a 250 ml Ricardi chamber, and we used a 3.5 ml enzyme solution per gram pancreas, and we purified the islet cells and cultured the islet cells because we want to know how is the islet culture recovery, followed by, we did all the quality control assessment. The procedure is not a rocket science, but it's a time-consuming procedure. It is equivalent to processing 3 human pancreases in a day. But this Trisector pancreas model educated us a lot. We noticed lots of new information. For example, we tested extreme dose of collagenase in one lobe and the extreme dose of protease in another lobe, and compared with the standard enzyme dose. And we had also opportunity to test, all currently available clinical enzymes from Roche, Servo, and VitaCyte. And then, it's a direct comparison to see, how these enzymes are performing during our islet isolation. So, because, at some point, we wanted to know, if you use an extreme dose of collagenase or extreme dose of protease, do you really kill the islet cells? Or do you really damage the pancreas if you use extreme doses? I'll share the results with you a little later. And then, this model was helping us to test, what is the effect of class tryptophan or combination of different proteases in one lobe. Important, then we also tested different ratios, the standard ratios of C1 to C2 is 60-40. So if you alter the ratio to 40-60 or 70-30, what are the results? Predominantly, we tested all these enzyme combination in older donors before we move on to younger donors. One interesting observation, for example, regardless of the enzyme I used, either higher dose of collagenase or higher dose of protease, some are unique. For example, if you notice quick digestion in one lobe, the same I observed in all other lobes, regardless of the enzyme dose or ratios. So then, for example, if I noticed fragmented islets in one lobe, I see the same phenomenon in all the lobes. So it clearly indicated it's not the enzyme, it's the nature of the pancreas. If the nature of the pancreas gives mass or or fragmented islets or quicker digestion, it is primarily due to the nature of the pancreas, how the procurement was done, what was the exocrine cell status. All those factors really played a major role. Before we moved on, after validating this Trisector pancreas model in older donor, we wanted to test different enzymes in younger donor. So first we characterized younger donor collagen and basement membrane composition, because without knowing that, it's difficult to really design the enzyme. we measured high collagen content in young donors compared to older donors. So generally our assumption is, when, in older donors, we think, more collagen content, but in younger donor, we noticed more collagen content. We measured high collagen content in young donors compared to older donors. We noticed that type 4 collagen levels here, type 4 collagen and basement membrane proteins, especially laminin and fibronectin levels were higher. So based on this observation, we designed the enzyme. So we used VitaCyte enzyme collagenase and BP protease and tested in this Trisector pancreas model. So, in a standard dose plus increased collagenase dose and increased neutral protease dose. So first we tested this to see, where we see free islets in younger donors. Then in subsequent experiments, based on this observation, we tried with the other, vendor enzymes, including Roche and Servo enzyme. And we used the same combination of, neutral protease from Servo and thermolysin from Roche. So, and as I mentioned earlier, we altered the lobe for every combination. So we, if we use a standard enzyme combination for the head lobe, then obviously in the next isolation, it will be in the body or in tail. So, increased collagenase concentration, increased protease concentration. So those ones were tried with the same approach. So, when I summarize all the results, in increased protease concentration, we had a higher recovery when compared to standard enzyme combination, as well as increased collagen concentration. So from a mantle islets, we get like nice free islets, predominantly many free islets we observed even at the time of switch. And since we used a higher amount of protease, we wanted to check whether any damage to the, islet cell membrane. So by using various staining method as well as scanning electron microscopic approach, we carefully check the surface of the islet membrane. Then after this Trisector model, as I said, we tried in whole pancreas islet isolations with the 3 different enzyme suppliers, including Roche and Servo enzyme, as well as in VitaCyte combination. And we got many nice free islets. They are viable. After culture based on we carefully monitor the culture recovery and we check their viability, dynamic insulin release, and diabetes-induced mute mouse model bioassay, and we had the outcome which are kind of similar to what we see in older donor. So I think the fundamental, even myself, I wanted to know, because we are exposing the pancreas to higher amount of proteases, whether the proteases will cause any kind of effect. So in my view, even the current dose of collagenase and protease exposure or increased dose of collagenase to protease exposure, in my view, all are same, because any damage, it happens to islets with the standard dose or increased dose are similar. So that's what we noticed in our islet culture recovery. So then finally, we went back to the original Milan protocol. This study proved our hypothesis. For example, they had a nice free islet cells, over 88%, using higher amount of collagenase and protease. In this case, it was a collagenase feeds and it contained a large amount of neutral protease. So higher the dose, it really helps to get free islets, especially from the younger donors. So now I would like to summarize increased dose of protease, either depending upon what you use, either neutral protease or thermolysin or BP protease with the standard collagenase can be utilized effectively to obtain mantle-free islet cells from younger donors. And the enhancing enzyme exposure, actually this is also a critical point. It's just not only the enzyme dose, we have to very minimize the mechanical digestion in the cardiac chamber. And based on our Trisector pancreas model testing various enzyme combination, I would strongly suggest, thermolysin is more harmful compared to neutral protease or BP protease. That's kind of our observation. And the tail portion of the pancreas contains large number of islet cells. Regardless of the enzyme dose, you get higher number of islet cells from tail portion. And these studies are described in this paper. And recently, we published this paper. This is our pediatric islet isolation experience from auto transplantation cases. With this, I stop. I would like to acknowledge all my colleagues, friends from Pittsburgh, Minnesota, Louisville, Colego, and all the funding agency and organ. Thanks a lot.
Thanks a lot, Dr. Balamurugan, for this great presentation. In between, we had some, I think, internet issues, but I think everything worked well. So if you have any question, please use the chat system, send them just over so we can handle these right away together with Bob McCarthy. Just want to mention that VitaCyte and also we will continue with this webinar series, which will focus very much on islet isolation. The next webinar will be in January, and the focus will be on for islet isolation from pancreas of chronic pancreatitis patients. So I will start with the first question which came in. Do you have any experiments with edema of donor pancreas? I mean, pancreas looking like distended immediately after unpacking from transporting box before injection of collagenase. And when touched, the feeling is very soft, like touching a mud. Can you comment on this?
So it means like a kind of edematous type of pancreas. I mean, before you distend the pancreas with the enzyme solution, and how's the pancreas morphology? Maybe you can repeat the question one more time.
I think just to let you all know, we will answer all the questions again afterwards by email if we have some problems. It seems to be that somebody likes to know about your experience concerning donor pancreas from edema. That means that the organ has a different experience. It's feel like mud, so it's very soft. And I don't know whether you can comment on this right now.
Again, the term, edematous pancreas, it's very vague. I believe, almost all pancreases are coming with some degree of edematous situation. Our experiences, for example, when we process pancreas with a very short cold ischemia time, we see a large amount of embedded islets. We could see large amount of UW or HTK stayed inside the pancreas. It causes some enzyme inhibition, and we see a lot of embedded islets in those scenarios. Other than that, either regardless of whether pancreas is edematous or a normal appearance, we process and we try to get maximum number of islet cells.
Okay, great. I think I will go over and hope we answered this question to the next question. During your tree pancreas digestion study, did you notice a increase of digestion time when using extreme versus normal enzyme levels?
See, it's a very good question. See, I think that is the Riccardi chamber system. Main advantage of Riccardi chamber system is this dynamic nature. In case if you feel your digestion time is very short, because of a higher enzyme dose, you have the opportunity to quick. So in our experience, I would say we didn't see any difference compared to standard enzyme dose. When I used the extreme dose, we see similar digestion time. We never saw quicker digestion time. That's why I specified, in the Trisector model pancreas, if I notice quicker digestion in one lobe, I see the same pattern in all other lobes. And remember that our our Trisector pancreas model, it's a blinded, we don't know, which enzyme we are really using at that time. So we see a normal digestion time.
Okay, great. Going back, the next question would be, what is your experience with cold ischemia time? It was repeatedly discussed in eagles that it should vary between 3 to 8 hours. Do you think that we should wait 3 hours, or can we start immediately?
I would, this is my own experience. I don't, when I get very sharp cold ischemic pancreas, I wait at least 4 hours before really process, or I flush the pancreas with the plain Hank solution, try to remove the cold storage solution which are inside the pancreas. Longer cold ischemia, obviously it affects islet yield, regardless of the enzyme dose we use.
Okay, great. Here comes somebody who thanks you a lot for this great presentation and added a question. Do you systemically add calcium chloride to your enzymes, for example, Observer, Roche, VitaCyte, or others?
Yeah. So I think we don't add calcium chloride or pulmozyme to our islet isolation for a long period of time. I would say since 2006 onwards, I use a plain Hanks medium to prepare my enzyme, because adding calcium chloride, without calcium chloride, yeah, you can digest the pancreas very well. Again, we don't use it. I don't use it for a long time.
Okay. I think another longer question, but I think I will try to read it to you because it's quite of interest. Again, thanks for the presentation, and also that you mentioned the publication which mentioned the split pancreas model that Nick London and Paul Johnson developed an ancestor already in 1993. And his question is, you have shown that with your protocol, low BMI is no longer a restriction to efficient islet isolation from young donors, but your CIT time seems quite short. Are you able to isolate good islet numbers from younger donors regardless of donor variables, or are you still restricting other donor variables? I have to check it down because variables considerably.
So, yeah. For any clinical trial, either CIT clinical trial or our own phase 2 trial, we prefer to get pancreas with larger BMI because we want to get more than 70 gram pancreas, because the pancreas, gram pancreas, plays a major role, because we want to get more than 350,000 islets. With the smaller BMI, generally we use it for our research purpose, or sometimes when we do retransplant, because retransplant islet release criteria is only 4,000 islet cells per kilogram body weight. At that time we used. Otherwise, predominantly for clinical trials, I think even the cutoff, it's we prefer to take more than 25 BMI cases.
Okay. Did you mention, or did you realize any difference between pre-treated patients, for example, after chemotherapy or whatever, in compared to healthy ones or normal ones?
Never studied.
Yeah. So extensive analysis of donor management, how donor management or their blood parameters, how those factors really affect the islet yield. One, either higher amount of AST, ALT level, or especially the creatinine. Whenever we see higher creatinine, we don't prefer those organs, because we believe there is a less blood supply to the organ, so the creatinine levels are high. But other than that, the other lab values, regarding sodium, potassium, plus all other lab values, generally we accept those pancreases. One example is in the beginning of our clinical trial, we reject pancreas with the higher lipase levels. Amylase, generally we see, high quantity of amylase, but lipase levels, increased lipase is a kind of indication of acute pancreatitis. But we prefer to take those organs. Actually, we get like a firm pancreas and get good number of islets from those ones.
Okay. Now, I think one of the last questions is a very technical one. Have you various enzyme perfusion pressures to lower than standard pressure, like 80 mm, to see if it has any potential effects on mantled islets?
I see. I think we compared machine distension with the pressure monitoring compared to standard hand syringe injection approach. We didn't see any difference. I think not only for this study analysis, for other studies too. What is the general effect of hand syringe injection versus the pressure monitoring? So we didn't see any difference.
Okay, I think that might be a question for you and for Bob. Your data show that increasing the amount of protease activity can improve recovery of free islets from young donors' pancreas. Calculations normalizing all enzyme units to VitaCyte NP units and found that if you see 100K VC units per gram tissue as a reference, then in your experiments, Nordmark NP activity had a 34% higher NP activity and Roche had a 60% higher NP activity than the reference material. As you showed earlier, thermolysin had different islet morphologies than those isolated with CHNP in normal adult donors. Can you comment on the difference in islet morphology using the dose of thermolysin in young and older donors?
Yeah. So, it's our consistently we see poor islet morphology with thermolysin, because again, at the time of islet count from 3 different preparation, those samples are blinded. When I see poor islet morphology or some kind of fragmented islets, it is always correlated with the thermolysin compared to neutral protease or BP protease, or even for some studies with class tryptophan. So thermolysin is maybe it's a very aggressive enzyme, but younger donors, they tolerated very well. That's why we could see some nice free islets. And when we use a higher amount of thermolysin or any kind of protease, we are very careful during the digestion step. As soon as we see some free islets, we immediately switch the basically stop the digestion process. So that way, we don't allow the even younger donor or older donor to go into over digestion process.
Okay, great. I think perhaps another one which seems to be of interest for everyone. You discussed several modifications to the islet isolation method to improve islet recovery from young donors. Can you rank these modifications by order of importance? What other modifications did you try but did not appear to make a difference?
I see. I think in our recent paper, in the auto transplant in AJT, we clearly described what. So I think the key step is how you really digest the pancreas. The first priority is higher protease. Whatever the protease you use, you increase from your standard. Then very prolonged enzyme distension. It's a kind of static type of digestion will really help. And then third step is slow shaking the chamber. So I think those are the 3 steps. Starting from the enzyme selection and with in the chamber. So with that period, because in the first sample itself, you can see if the islets are embedded, it's all embedded. So I think again the dose, prolonged enzyme injection, and very minimal mechanical shaking in Ricardi chain. Those are the first 3 things.
Okay, I discussed with Bob McCarthy the effectiveness of rescue purification. Can you comment on this, whether this can improve the islet recovery of young donors?
Definitely rescue purification, when you do any additional purification after your standard, rescue purification definitely recover islet cells, but still we lose a lot of islet cells. That is in the co-bag, when we count islet cells in the co-bag, still we lose a lot of islet cells. We prefer to collect all those cells, minimize, increase the recovery of 80%. So it helps, but definitely, free islets would really help to get more islet cells.
Okay, perfect. So I don't see that more questions coming in right now. So then I thank you again very much for your great presentation. Also, Bob, for helping me to run this webinar. And I like to say goodbye. And Bob, I give you the last word, also to say thank you and perhaps to promote the next upcoming webinar.
Can you hear me?
Thanks a lot.
Yes, of course, we can hear you.
Thank you, Bala, for a great presentation, and thank you, Peter, for hosting this. I thank all of you who still remain with us for participating in attending this webinar. Over the years, I've noticed that a lot of people want more information on more technical details on islet isolation, so there's more discussion about issues, because as all of you know, you're a small clique, so to speak, with a very narrow, with a very important expertise. So we are planning, VitaCyte is planning to have webinars every other month. Bala will do the next webinar on islet isolation from chronic pancreatitis pancreas in January, probably about the same time at the end of January, and I'm planning to have other ones talk about mechanisms of how collagenase works, so you can understand what the implications of what the enzyme is doing to improve, to make it easier for you to start evaluating different enzyme factors if you so desire. Again, I just want to sign off and thank you, and thank Bala for a great seminar. It was very comprehensive, and I wish you all to be safe in this trying time.
Yes, thanks also from my side again, and of course stay safe. I think it was a great opportunity in these times when conferences are more a problem. We cannot travel to meet each other at some nice places. So I think I will close the webinar now, and thanks a lot. And for everyone here in Europe, have a nice evening. For everyone in the States, enjoy the day. I hope you have good weather over there, and stay safe. Thanks again. Bye-bye.
Yep, thank you.